Cure sometimes, treat often, and comfort always. Hippocrates. Hi, I'm Frank Speidel, a retired emergency physician and recovering hospital administrator. And welcome to The Doctor Is In. In this show, with the help of guests, we explore healthcare in the U.S. and its interface with our society. Now, I am neither an infectious disease specialist, nor an epidemiologist, nor a public health official. For guidance in healthcare decisions, I recommend you consult your primary physician. I have been blessed by many, by family, by friends, by strangers, and most of all by my patients who have honored me with their trust. In foolish innocence, I began in medicine, thinking I was there to cure. I learned that we cannot always cure. To be sure, reducing a dislocated shoulder is satisfying both to the patient and to the practitioner. And the toddler who presents with the subluxed radial head, better known as a nursemaid's elbow, provides smiles to parents, to child, and provider when successfully reduced. But sometimes we have to deal with pain. I learned we cannot cure everything, and pain can be a stubborn foe. I also learned that pain is subtle and nuanced adversary, capable of massive surprises. And I have much still to learn about treating pain. Early in my practice at Chester County Hospital, I was stunned to see and actually hear a tan, gray-haired lady in English riding breeches and boots hobble into the ED to the crunching sound as the bones in her broken ankle grated on one another. She wouldn't let us cut off her riding boot for the fractured ankle. She said not a word, just broke into a sweat as we pulled off the boot. But I think pain is unique to each of us and is debilitating. And chronic pain is chronically debilitating. I think we owe it to our patients to treat their pain with intelligence, care, and recognize its uniqueness. Joining us today is Dr. Asare Christian, a physician committed to caring for those who are suffering. Dr. Christian continues a wonderful tradition of The Doctor Is In, where I interview thought leaders in medicine. My guest is massively educated and experienced, as most are, and I am left praying I not embarrass myself. Dr. Christian, a physiatrist specializing in pain. His education and training includes such never-heard-of organizations as the Johns Hopkins, Harvard, and MIT. Dr. Christian, welcome to The Doctor Is In. And what did I get wrong?
I think you were perfect. Thank you so much for having me, and glad to be here.
Did you always want to be a doctor?
Yeah, so my story relating to becoming a doctor goes back when I was a little bit younger. And a friend of mine growing up in a small village in Ghana who died of sickle cell. At that time, I wasn't really sure what sickle cell was. And I was wondering, and I was asking people, why did my friend die? And I did not die. And apparently he got a mosquito bite and then I survived. So my interest in medicine kind of dates back to this experience as a young person where a friend of mine died because he had sickle cell and I did not die. And the reason for that was the fact that even though I had, in Ghana growing up, I was a carrier for the sickle cell. So in that environment, those that develop sickle cell because of poor infrastructure are more likely to die. And then those who have AA, who don't have the sickle cell, tend to get affected by mosquitoes and get malaria and may also die. So by default, the environment selects for something we call heterozygote advantage. Basically, if you have AS, then you're more likely to survive in the pool. So that's what I had. So back then is kind of where my peak in science and medicine began, and then have subsequently had some experiences in in undergraduate, was interested in biochemistry, organic chemistry, and then decided to work in a hospital to see if I liked the personal interaction with people, because that's what I was afraid of. And then subsequently that cleared itself up, and here we are.
You certainly are a people person. That's one of the things that comes across, Asare. When I first met you, you are an outgoing person. I love the way you always look at people when you talk to them. We don't always do that, do we?
No. Yes, and even also I think there's some cultural differences as well, because even growing up in Ghana, when you talk to people, you don't really look to them in the eye. So different cultures, even looking people in the eye becomes a little bit of like a disrespect. So it's a very interesting thing. So when I move here, I have to kind of get acclimated to look into people in the eye when you're talking to them.
I wish I could. We are so. Speaking for myself,
Yes.
I am very much aware that I see everything through my culture, and I don't have the breadth that I need to understand that what may be offensive to me is considered respectful in another culture. That what I see as indifference is deference, and I've got to learn that more.
Yes. Different cultures, different ways of seeing things. Yep.
Well, what does physiatry, other than the word I always struggle to pronounce correctly?
Yes, and that's a great question because a lot of people don't understand what physiatry is, or even people in medicine, right? Some of our people in medicine. So physiatrist is a physical medicine and rehabilitation physician. So we kind of have the same experience, and this is just talking to general people, where we go through medical school, we do residency, and part of our training, we focus on function. So physiatry, in contrast to the cardiologist who is focusing on the heart, or the GI doctor focusing on the GI system, or the ER doctor doing everything, we focus on function. And basically the idea is, irrespective of whatever the disease state, so if you have stroke, if you have MS, if you have Parkinson's, if you have back pain, we focus on how do we get you to be functional? Whatever the impairment or whatever the disease state is, you still have to be able to get up in the morning, go to the bathroom, brush your teeth, put on your clothing, the things that we take for granted. And we recognize that when people have disabling disease state with neurological injuries such as stroke or brain injury, all of those things become very hard to do. So from a rehab standpoint, or from a physiatry standpoint, we focus on how do we get you to be healthy so you can execute those functional things. Yes.
So physiatry is a natural growth into the relief of pain. Because as we know, or we should know, pain is terribly debilitating. Chronic pain will change lives. And if we can, just like if somebody has a limp, and we can help them with their gait, if somebody has pain, and we can help them with their pain, we have done a lot for them, returning them to their function.
Absolutely. So I think by default, even physiatrists are really good at really managing pain, because we also focus on musculoskeletal medicine. So part of our training is we learn how the whole musculoskeletal system work, and trying to connect and making sure that people can perform optimally becomes a function of taking away anything that is affecting that process, such as pain. And pain can inhibit people from doing so many things. Pain has all this disabling as well as comorbid things that goes on with pain experience. So becoming a physiatrist, we really understand how we manage the pain so it translates to function. So our approach is not, let's just give you a pill. Let's give you a pill so you can go for a walk. Let's give you a pill, or let's get you to have some type of intervention so you can go and have dinner with your friends. So it's all about translating to function, and that's our approach to pain management.
You mentioned, you allude to, there's different modalities for treating pain. Tell me, what modalities are out there?
Yeah, so that becomes a function of who's a patient, what kind of pain is going on with them, and trying to figure out what type of assessment to even come to a place of how do I get clear on what's going on with this person and what type of treatment will work for the patient. So in a very kind of broad way, when we are trying to address pain, we look at from pharmacological and non-pharmacological approach. And pharmacological, as we know, is the things that we can do with medicines. The non-pharmacological approach is what involves in other mind-body approaches. And that is really important when it comes to pain. Because when we talk about pain, pain is defined as an unpleasant experience that have a sensory and an emotional component. And this is something I want to kind of try to push out there, because what it is when we are addressing the pharmacological, we're using pharmacological interventions, we're just basically working on the sensory component of the pain signal. We are not doing anything regarding the emotional component. And this is why we have a lot of people who are still in pain despite having injections, having medications, and not really getting a good understanding of, what pain is to be able to kind of get us the result. So mind and body approaches are very fundamental, because we know that pain has this other mind-body connection that we have to address. So pharmacological, non-pharmacological. And then when it comes to chronic pain management, we think that pharmacological intervention should complement, not replace non-pharmacological treatment.
I appreciate that we are each individuals.
Yes.
And unique. And as my lady from getting thrown by her horse taught me, I can't judge pain just by looking at somebody. That was one of my learning experiences. What is something you'd want to share with other physicians, all physicians, and your patients about what we don't understand about pain and where we get our understanding of pain and gets us in trouble?
Yeah, so I think that's a great question, because part of the issues we have with, first of all, so many Americans are in chronic pain, about 100 million. So
wow.
In fact, there is more people in chronic pain than diabetes, cancer, and cardiovascular disease combined, because pain is this experience that we all go through. And the issue with how we treat pain is we don't have a clear understanding of what pain is. And I think, or maybe we do, we just forget. So I think for physician, what, again, I want people to understand is this idea that pain has an emotional and a sensory component. And it's always a personal, subjective experience that is influenced by biology, psychology, and sociology. Okay? So when we're thinking about pain and treating pain, and we're only looking at the biology, right, there's some people who have predisposition to chronic pain development. There is physiological, pathological things that goes on, but we have to think about what type of experience that these individuals have had in terms of their psychology. The environment that they grew up actually influence how people talk about pain. So even being from Ghana and being in America, there is different ways of how we look at pain, right? Because America, we make up, about maybe 4% of the world population, and yet we consume about 80% of the opioids in the world. So there's this culture that also influences what pain is. So I think it's super important for physicians to understand that we have to be able to effectively treat pain. We can't just do injections and talk about patients taking pills, but we also have to talk about, are they sleeping well? Do they have trauma experiences? Do they have other stresses that actually plays a role? And I think that's also important for patients to understand that it's not just what is on your x-ray, right? You come in with back pain and we take an x-ray of your back and we go, yeah, you have herniations. And we fix that. We get you injections, people get surgeries, and then fix those things, and patients still have pain. So what else is going on? And this is where we talk about sleep playing a role in perpetuating pain cycles. Nutrition, what you eat, because patients will come and tell me, oh, nothing works for me. I've tried everything. I've done physical therapy. I've done acupuncture. They do all of those things without really changing the habits that keep them in pain. So I think it's really important for patients to understand that there are so many things that influence pain, your emotion, your cognition, your thoughts, how you feel, if you're not sleeping. And we can all kind of validate some of this experience. So what I do, or what I like patients to get from my interactions with them, is to get them to connect the dots. That when you didn't sleep well, your pain went up, right? Because pain to patients always feel like danger, something is wrong. Mm-hmm. Pain doesn't mean something is wrong. It's just a signal. And it's a function of what your brain is interpreting that signal to be. And it becomes, that interpretation is through a lens of your world experience. So this is where we need to get patients to also understand that your anxiety, depression, all of these things actually plays a role in terms of how you interpret pain signal.
I would share with you that is a massively advanced view compared to what I grew up with in medicine. For people in my time, it was tough it up. You got to be a tougher person about this. We can't make everything right. Some of the things that destroy us are subtle. Yeah. And that's part of our environment that we do not normally are not aware that the relationships at my place of work are challenging and destroying other things in my life. And sometimes that other thing is I can't fall asleep at night because of my headache. Yeah. I wake up. Tell me about that. Is there any pattern of sleep that you find suggestive that someone is going to have recurring refractory pain?
Yeah, so people come to me, and actually that's a great question, because what I do is, in my practice, when people come and they've been everywhere else, when they come in, my approach to trying to help them with their pain becomes, let's get you healthy. When you're healthy, all the interventions that we do actually gets better. So what I do is I ask them about sleep. How is your sleep? I don't sleep well. What is your nutrition? What are you eating? Do you exercise? How is stress? And then I kind of pick apart, depending on where they are. If sleep is an issue, we talk a little bit about sleep and the importance of sleep. And when you don't sleep, you actually create more pro-inflammatory state. It's going to perpetuate the pain cycle. If you don't sleep, getting good sleep, meaning REM sleep, stage 4 REM sleep, that's when you're regenerating, so your body can heal and your cells, immune cells that are activated and causing all of this pain signal actually take care of itself. So a little bit of education for patients to understand that, yes, if I don't get good sleep, pain doesn't get better, and they don't connect with that. And I've had patients where by first getting them to sleep, they actually heal better. And it's super fundamental for individuals to understand the importance of sleep. And we all can validate that. If you don't sleep very well, you wake up the next day, you don't feel great. So imagine what else is going on in your body if you're not really getting good sleep.
You used the term, for our audience, could you amplify and talk about what's a pro-inflammatory state?
Yeah, so pro-inflammatory state just means a state where your body is making more inflammation markers or creating more inflammation. So you have cells in your body, and it's not that inflammation is bad. In fact, we need inflammation to allow us to heal. The problem is that we don't want inflammation that stays longer than expected. So pro-inflammatory state just means a state where your body is making more inflammation, and it could be a function of what you're eating. Sometimes certain food will make more inflammation in your body, and that may make pain goes up, or your hands will swell up because patient will come to me and go, oh, I don't know what happened, doc. My hands are swollen. I'm aching today. I'm not sure what happened. And then when we say, go back and look in the last 48 hours, what did you eat? So people can connect some of this that, oh, you know what, when I drink beer or when I do, and then people are able to connect and they're able to kind of move away from creating this state of inflammation that kind of keep them in pain.
What we ingest before we go to bed, so that before we try to pass out and sleep, our ingestions, that can affect our sleep.
Absolutely. And one of the things that we see now is with cellular phones and iPads and all of these things and all this light exposure. So what we're doing is we're really not getting our nervous system to get to a place where it's calming down so then we can get into this good sleep architecture. Because the thing is, it's not just the quantity of sleep. It's about the quality of sleep and how much time are you spending in REM sleep versus non-REM sleep. And when those things are not taking place, so many things become affected. You have dysregulated in circadian rhythm, and we know that can implicate even your metabolic profile, your energy level. When you're sleeping, that's when you're cleaning the brain. And people that don't sleep very well, there's some relationship between that and developing neurodegenerative disease. Because when you're sleeping, get into stage 4 REM sleep, you turn on this lymphatic system where you're actually cleaning the brain from all the junk. So it's super important for individuals to understand that spending too much time on the tablet or something else before you go to bed is not a great thing. Even eating late before you go to bed is also not a good thing, because all of that can implicate how you feel.
Dr. Christian, I would venture to speculate that there are parents out here that are thrilled to hear you say, we've got to get off the tablet, we've got to get off the iPhone. I am stunned to see how much we have all become, even dudes like me who have had a few birthdays.
Yeah.
We've gotten addicted to that phone, and we are afraid of missing out on something. My son calls it FOMO, fear of missing out.
Yes. It's a bit unfortunate. And in fact, one of the things, I've kind of read some statistics about how sleep is one of the biggest issues that younger people are facing now.
Wow,
because of that. And we're worried about, sleep is so fundamental. We spend a third of our life in sleep. So there is, and we understand the biology behind all of that and the science behind importance of sleep. We're still trying to understand why. But we know that, and as a patient or as a person, you know how you feel when you don't sleep. So it's very, very important. And I think for young people, this is something that we're worried about, that a lot of young people are not getting good sleep. Their sleep are disrupted because they have all these stimulations from games and from and phones and things like that. So I think trying to figure out a better way to manage that will be something that we all have to work on, trying to figure out how we do that for kids.
Where do you see coming up in pain management? What are the new things you see coming on the horizon that we're going to probably see in the next 5-10 years?
Yeah, so I think part of that is moving to a place where we're trying to prevent pain. Because this idea of chronic pain, right? We'll have two people, somebody will, maybe fall, and they, as you saw in the ER, somebody may have a fracture. You reduce it, they get better, they move on. Another person will have the same fracture, and then they will develop this complicated history of, pain not getting better, their whole life become affected, and so on and so on. So I think in terms of moving forward in the future, innovation, it becomes really trying to figure out how do we prevent chronic pain development. And this is where we can have our own traditional pharmacotherapy and other things like that. And some of the things that is coming out that I'm excited about is regenerative medicine, trying to figure out how do we regenerate processes. So if you have arthritis, if you blow up your knee, you're a young person and you blow up your ACL or something like that, can we get you on some specific treatment, which we can, with regenerative modalities that prevent or slow down the progression of disease. So I think all of those things are important. There is also digital therapeutics, so there's a lot of delivery changes that are also occurring. And I think that also give patients the ability to be able to kind of be educated. Because one of the things I do with my patients is giving them all these apps that talks about the neuroscience of pain. Because people come to me and they have pain and they really don't understand pain. And if you're a patient, you've been in pain for so long, and I ask them, what is your understanding of why you have pain? They go, it's my L1 herniation or L4. They remember some anatomical description of the pain, but that has been fixed. You've had surgery, we fixed that, right? So they're not connecting the fact that, they go, oh, the surgery didn't work, I'm still in pain. But they're not sleeping, they're still stressed. There's all of these other things that are still there that need to be kind of brought into their awareness so that they know that this is actually playing a part in my pain perpetuation.
That leads on to I have always needed to recognize that individuals are unique, and their situation is going to drive our care, how we approach that situation for the patient. I am now learning that people learn things better one way than another. That the old school of just talking at the patient and telling them things, maybe it can be enhanced by providing them resources. Look at this, and let's talk about this on your next visit. Tell me what you think about where we want to go with that. Am I overreading that approach?
No. I think that's exactly right, because, we see these patients and they have this long history. And I think part of it, pain is such a subjective experience, right? Mm-hmm. And as you talked about earlier, the people are going to come and they're going to look fine. And they have all of this pain issues. So it's not this visible thing. Sometimes we can see when people are suffering, but for most people, we don't see that they are in pain. So it becomes really getting individuals with pain to really understand what pain is. Because the pain level that you tell me, if your pain is 6 and my pain is 7, it's, we don't have a really good way, even though you're recording as 6, your 6 may be somebody's 1. Right? Some people come to your office and they go, I'm in so much pain, and they're fine. They're sitting there talking. And then somebody comes in, my pain is 2. Oh my gosh, I can't walk. So it's such a subjective experience. So I think part of this is getting patients to really understand that what pain is, and that becomes a function of giving them access to some of this information. And then there's the good thing is there's so much information out there. People are also looking for solutions, right?
Yes.
So kind of doing some of their own introspective work and connecting the dots is what I think it will be helpful in getting people to get improvement in pain management.
Well, I am thrilled that we have people such as yourself who are making a career trying to get us to a better spot. Yeah. We underestimate, I think, how debilitating the chronic. It's kind of like that. The instability of the joint creates more instability. Yep. The more the joint the more we are deformed by our pain, the more we engage in things that don't help. When we disrupt our careers because of our pain, we actually take away something that tends to help most people. The distraction away from the self and out towards, I've got to get this project done, or I've got a shift to work in my case. That was one of that's something that I've spent some time learning. Interestingly enough, you have a master's in public health.
Yes.
There's got to be a story behind that too.
Yeah, so I've always been interested in understanding population health, and I'm from Ghana, so one of the things that you kind of grew up there is this idea of global health and population health, and really trying to figure out how do we keep people healthy. So when I was finishing residency at Hopkins, I have 5 in my class, and all 4 went into pain medicine. They all went to do pain fellowship. And even so, as a resident, I did not even want to do pain. I was like, I don't want to deal with pain. It's too subjective. It's too complex. You can't tell. There's just so many factors. So I didn't want to deal with that. So I said, I'm just going to go get an MPH, get a public health, so I can have a better understanding of how you solve problems at a higher level, at a bigger level. I was also interested in some leadership things. So that's what I went to do. And then when I was doing MPH, I came to find out that pain is one of the biggest public health issues that we have. And public health. What is public health? Maybe to the audience, public health is anything that affects a lot of people, costs a lot of money, and is preventable. And that's what pain is. Pain costs a lot of money. It costs more than cardiovascular disease and all the top disease that kills people. Pain costs about $560 billion a year. So it's a huge cost, affects a lot of people, 1 in 5, even now it's close to 1 in 3. And then it's also preventable, because if we can educate people about habit changes and all of these things that plays a part in their pain, people will get better relief and will prevent development of chronic pain. And I think it's important to also make the distinction of acute versus chronic pain. Acute pain, that's what kind of you deal with in the ER. Fractured things, they come in, we fix it, and those work very well with the biomedical model. But when people have chronic pain, that model doesn't work. Medication alone is not going to work. We'll have to get them to talk about nutrition, talk about their trauma, talk about sleep, talk about exercise.
Moving beyond biomechanical to an environmental global
Absolutely.
issue.
Psychosocial.
Of what is affecting and driving my patient into this dysfunction.
Absolutely. And then the other thing that's also good for me from the public health standpoint is, because of that experience, I have a global perspective in how to understand where a patient is coming from, right? We understand determinants of health. How do people even develop the pain? So it also gives you the place to understand even prescribing treatment for patients. If my patient needs to go, I want him to eat specific food, I want him to do specific exercise. If they don't have access to a gym or to a food, that prescription is not going to be relevant to them. So I think public health kind of gives you that global perspective, and in a way, it helps you to think a little bit more about what's going on in their lives before they get to your clinic.
Dr. Christian, I cannot thank you enough for bringing your insights and for committing to this field that we so desperately need. Yes. It's a delight. I'm obviously at the end of my career, but it is a delight to see people like you bringing the insight and the energy. I greatly appreciate it, and you're going to succeed extremely well, because we have need for what you bring. For those of you out there, I thank you very much for watching The Doctor Is In. Please be aware that there are people like Dr. Christian out there. I think we all have friends and family who are suffering from an intractable disruption to their life from pain that nobody seems to be able to get their hand on. Be good to yourself and look around for people like Dr. Christian. Thank you.